Good morning. All right, so the objectives for this talk, we'll be reviewing basic concepts in blood pressure monitoring and how to make the diagnosis of hypertension. We're going to talk about the basic differential for a child with hypertension, which is age-based. We'll be talking about hypertensive emergencies, of which there are two different ones, and then talk about the basic categories of antihypertensives and their side effects. So as I'm sure all of you know, when doing a manual blood pressure reading, we inflate the cuff around the arm. The idea here is that we are completely compressing the brachial artery, and by decreasing the pressure, you're allowing blood flow to return. And it's the sound of that blood flow that actually gives you your blood pressure reading. So what you're listening for are officially called Korotkov sounds. And it's actually the second audible beat that you hear that defines the systolic blood pressure. An important concept here is something called the auscultatory gap, and this is especially relevant for patients with pretty significant hypertension. So with patients with hypertension, as you first allow the blood flow back into the brachial artery, because of the high pressure, you can often have very high turbulence, which can actually obscure your Korotkov sounds completely. And so you might have a gap of 10 to 15 millimeters of mercury where you may not hear any sounds, which is why it's important always to inflate the cuff far above what you expect the pressure to be to ensure that you really identify the true systolic blood pressure. And then the disappearance of the sound when you have zero impedance of the brachial artery is your diastolic blood pressure. A few other issues to keep in mind. The first is cuff size. I think we're all aware of the issue with circumference, right? It's well marked on the cuffs, and you want to be sure that the arm fits, the circumference of the cuff fits within the markings on that, on the cuff. The reason why this is important is due to the distribution of the pressure. So if you have a cuff that is too small, the amount of pressure necessary to compress a brachial artery will actually be elevated, and it will therefore artificially elevate your reading. If the cuff is too large, you will actually require lower pressures to compress the brachial artery and again, cause your reading to be inaccurate. One other thing to keep in mind though is also cuff length. So this is particularly relevant for our lanky, skinny teenagers. And so their arms may actually fit into a small adult cuff, but the cuff itself may cover only a half or a quarter of their upper arm. The length of the cuff actually should cover about half of the humerus, which is really the majority of the exposed arm. And so it's important to keep both those factors in mind, again, to provide the appropriate distribution of pressure to get your compression correct. Clothing or really anything else that interferes with the compression of the brachial artery will alter your reading. And then extremities, certainly all of our standards are based on readings in the upper extremity. Now there's mixed literature. There's actually some literature that says in infants, non-ambulatory children, leg pressures may actually be okay, but certainly we know that in older children and adults, leg pressure should be much higher than the arm, and therefore cannot be used to actually diagnose hypertension. Oscillometry, or automated blood pressure monitoring, we all use it. We use it in our nephrology clinic also. So these machines will inflate the cuff and will oscillate between full and zero impedance, and based on those readings, we'll calculate a blood pressure based on that brand's algorithms. There are differing algorithms for different brands, which is why you may see some variation between different machines. So very quickly through some definitions. So hypertension is defined as a systolic or diastolic blood pressure greater than the 95th percentile for age, gender, and height on 3 different occasions. And we'll be talking about the percentiles very soon here. Prehypertension is a reading, 3 readings between the 90th and 95th percentile. Stage 1 hypertension are readings between the 95th and 5 millimeters of mercury over the 99th percentile, and stage 2 is a reading greater than that. These staging is largely from adult literature, indicating that the correlate between the stage of hypertension and the risk of cardiovascular disease kind of matches directly, as you can imagine. So the worse the hypertension, the worse the risk for cardiovascular complications afterwards. So in pediatrics, these percentiles are based on this working group report, this National High Blood Pressure Education Program working group from 2004, reviewing a large population data from the 2000 NHANES study. So I'm sure many of you have seen this. These create these tables that provide your percentiles for height around the top, and then your age along the side, and you match them to figure out where your patient lies. And that'll give you your 50th, 90th, and 95th percentile for age, gender, and height. What's important to remember is that these charts are created from population norms. These are looking at percentiles amongst large populations. The challenge with this is that this actually varies quite a bit from how adults define hypertension. Adults define hypertension based on outcome. So there are many studies, this is just one actually quite a while ago, but was pretty significant at the time, indicating that in adult literature, the risk of vascular mortality, heart attacks, strokes, etc., started with blood pressures greater than 115/75. And this is, again, for an older adult population. So they're basing the definition of disease based on the outcome, which makes a lot of sense. Unfortunately, no such information exists for pediatrics. And so we're really limited to define hypertension based on our population norms. It's kind of where we are. It is a limitation, but we do know that there are vascular complications that do arise in children with hypertension. Moving on to the evaluation. So secondary hypertension, meaning hypertension that has a defined etiology, is seen in up to 50% of patients, and that percentage actually is inversely related to age, meaning the younger the child is, the more likely you are to find an actual cause for their hypertension. Your differential does vary based on the age. As you can imagine, in infants, a lot of the differential is based on congenital malformations. So we may see different renal malformations, cystic disease, autosomal recessive polycystic kidney disease is a classic presentation for severe hypertension. Renal dysplasia, again, congenital, may also be an etiology. You could see a variety of endocrinopathies, such as issues with renin or aldosterone. Hyperthyroidism could be a cause. And then vascular issues, again, these could be, again, congenital anatomic variations with renal artery stenosis or coarctation. But again, we also often talk about umbilical lines, umbilical arteries possibly causing renal arterial injury. In school-age children, we move along to a few more acquired diseases. So reflux, recurrent UTIs, and renal scarring certainly is a common, in our population, a relatively common etiology for hypertension. And then there are a variety of acquired nephritides, which could occur in this age group. And then there are a variety of syndromic associations, which the boards always like. And these usually present in the school-age time period, usually not at the neonatal period. So with Williams syndrome, there are a variety of vascular anomalies that are associated, including renal vascular disease. Neurofibromatosis, there are a variety of associations that can cause hypertension. Pheochromocytoma with NF is well described. Renal artery stenosis, once again. You can have some neurofibromas actually compressing on the renal parenchyma or the renal vasculature, which can cause hypertension. And lastly, coarctation has also been associated with neurofibromatosis. Last example is tuberous sclerosis. This can also cause primary cystic disease. You also may have some some tumor suppression, or these tuber develop within the kidney and causing the similar types of vascular compression. And then in adolescence, certainly these days, essential hypertension is the most common cause of hypertension in adolescence, largely due to obesity. Cushing syndrome is another cause, which we'll talk about more. And then drug-induced, certainly something to consider in this age group. So talking a little bit more about a few of these diagnoses, the first is renal artery stenosis. So this is the most common correctable cause of hypertension, aside from obesity. You certainly could say that you can reverse obesity, and in that way you could reverse hypertension also. The clinical clues for RAS, one is an acute rise in blood pressure. So the classic scenario is you see a child for a well visit, and they have very normal blood pressures on normal exam, and then 6 months later they're seen and have very, very severe hypertension, which is largely asymptomatic. On imaging, you may see renal asymmetry. This is due to chronic hyperperfusion of one kidney due to the vascular compromise. If you have a patient who you think has essential hypertension and you treat with an ACE inhibitor, you may actually induce severe acute kidney injury in these patients. And lastly, patients who have what you believe is essential hypertension but are very difficult to treat. So you start one medicine, it's really not working, you end up adding a second, and even more. Usually those patients really require more of an evaluation, and renal artery stenosis certainly is a possible cause in those situations. For diagnosis, the gold standard is angiography. So we're talking about in the cath lab, going through the femoral vein, very, very invasive type of procedure. But this is certainly the gold standard for diagnosis. But again, it's something we usually don't do because of the invasive nature of that study. As a result, we do resort to imaging, and thankfully, the imaging modalities certainly have improved quite a bit. Most studies will say that MRA or CTA will provide more than 90% with sensitivity and specificity for this diagnosis. Usually for us, we start our evaluation with a Doppler ultrasound. Certainly this is not as sensitive. Studies will vary 50 to 70% for sensitivity and specificity with the study. But the reason why we do it is that most patients will need a renal ultrasound. We're looking for the overall assessment of the renal parenchyma, and the Doppler is very easy to do. It doesn't require sedation, there's no radiation. So it's a very easy preliminary screening study, which is why we start with that before we go right to an MRA, for example. A random renin level, as you can imagine, thinking about the physiology, you have a kidney that is chronically hyperperfused. Renin will be very active because the kidney feels it doesn't get enough blood flow and wants to adjust that by activating renin and angiotensin. So the level should be quite elevated. But the fact is that renin has a very, very short half-life, and there can be a variety of acute factors that can alter the secretion, related to volume, state, and activity level, and a variety of other things. Therefore, the actual sensitivity of renin is quite variable. It is something that certainly we screen, because if it is very elevated and positive, it certainly can be helpful. Etiologies of renal artery stenosis. As I mentioned previously, there are a variety of syndromic associations, including Williams syndrome and neurofibromatosis. Many, almost all vasculitides can affect the renal artery. These are systemic vasculitis conditions. Fibromuscular dysplasia, certainly a diagnosis more common in adults, but something we do certainly see in children. This has a description of a string of beads appearance on imaging. And there we go. So on both these imaging studies, you can actually see involvement of the entire length of the renal artery, where you see these dilations followed by areas of stenosis, providing that kind of string of beads appearance in both of those scenarios, classic for fibromuscular dysplasia. In adults, atherosclerosis actually is the most common cause of renal artery stenosis, certainly very rare in children. And then the wastebasket of idiopathic. These could be congenital malformations, or really things that for which we really have no true understanding of what happens there. Indications for revascularizations. For which patients do we consult interventional radiology or vascular surgery to try to go and actually fix this defect, this lesion? So a few different indications. The first may be chronic renal injury. So if you actually have a kidney that is not growing, and you can see evidence of chronic renal injury from chronic hyperperfusion, those are scenarios where we usually push the interventionalist to try to correct it, to try to salvage the long-term function of that kidney. The second is intractable hypertension. So if you're on your second medicine or onto your third medication, and the hypertension still is poorly controlled and the developing left ventricular hypertrophy and other types of issues, these are situations where we really are pushed to try to find a better intervention, better treatment for their hypertension. And then the last is the actual type of lesion that you see itself. So in most idiopathic cases, you may see a very short segment area of stenosis, and those are very easy to treat. You can balloon them, you can snip them, and have just reanastomose that lesion, and usually that is a definitive correction. And for those patients, we tend to encourage intervention because we believe the outcome will be quite good. In other patients who have vasculitis or those pictures of fibromuscular dysplasia, where the involvement is through the entire length of the artery, as you can imagine, trying to surgically correct this or even trying to balloon this would be extraordinarily difficult. And while we do often attempt in patients because of the severity of their hypertension, the success rate is much lower, and also the recurrence of stenosis is very high. All right, moving on to pheochromocytoma, a diagnosis often described but rarely seen. It's on everyone's differential for most everything. So a pheochromocytoma is a catecholamine secreting tumor. Now, officially, a catecholamine secreting tumor within the adrenal medulla is a pheochromocytoma. If you have such a tumor that is extra-adrenal, outside of the adrenal glands, that's actually called a paraganglioma. Physiologically and phenotypically, they are identical. The classic triad described is episodic tachycardia, headache, and diaphoresis, right? These storms of catecholamine release that have been described. But in truth, this is actually rarely seen in children. Most children who present with pheochromocytoma actually just have chronic severe hypertension and often don't manifest these acute symptoms of catecholamine release. Other symptoms that we can see is chronic weight loss due to, once again, the chronic elevated levels of catecholamines, hyperglycemia, and a dilated cardiomyopathy. Malignancy is very commonly associated with pheochromocytoma in children, which we'll talk about next. So there are a variety of syndromic associations, as I mentioned previously, NF1 being probably the most commonly cited, von Hippel-Lindau disease, Sturge-Weber, and multiple endocrine neoplasia type 2. In the majority of these are associated with a defect in a tumor suppressor gene, so in VHL. This is a mutation in the VHL, which is a tumor suppressor gene, resulting in a variety of malignancies that these patients can develop, including hemangioblastoma, renal cell carcinoma, and pheo. With multiple endocrine neoplasia type 2, if those of you who have studied know that there are these triads that come with these MEN diseases. So for MEN type 2, it is pheochromocytoma, thyroid carcinoma, and hyperparathyroidism. Last, there's a diagnosis of familial paraganglioma. Again, just another defect in a tumor suppressor gene, the succinate dehydrogenase mutation in this case. So for any child truly diagnosed with a pheochromocytoma, they really deserve a genetic evaluation for a variety of these associated symptoms that I described. So any child, again, of young age, which indicates our entire population, patients who have a family history of pheo certainly deserve a genetic evaluation, and if you have bilateral adrenal involvement, that certainly also deserves some kind of syndromic pursuit. Test of choice, I put an asterisk here because this actually has changed over the past several years. These days, the recommendation is actually to do plasma metanephrines. So we don't measure catecholamines because the half-life is incredibly short. Metanephrines are the metabolite of catecholamines, and even though metanephrines also have a relatively short half-life, it is longer than catecholamines, and therefore your sensitivity in your assessment will be greater, which is why we measure the metabolite rather than the direct catecholamine level itself. The general recommendation is to do plasma because doing a 24-hour urine in our young population is more challenging, and if you don't get an accurate result, your testing will be uninterpretable. That being said, in our practice, usually we do both. We do plasma and urine, 24-hour urines, whenever possible in these patients. Once you have strong clinical evidence or biochemical evidence of a pheo, the next step is to do imaging to try to actually look for this tumor. So that's through an abdominal MRI or CT. You can also do an uptake scan, such as an MIBG or an octreotide scan. If, for example, you don't see anything in the adrenals, you think it might be somewhere along, somewhere else in the body, you can actually do a whole body scan using one of these uptake studies. Treatment is surgery. This is pretty much the standard approach. It is very important to have very dense alpha and beta blockade because through surgical manipulation, you can cause significant amounts of catecholamine release in surgery, which can be fatal. So it's very important to have that blockade very heavily on board before they go into surgery. Surgery usually is curative, but once again, because of the high rate of malignancy and because of the genetic predispositions, recurrence is very, very common in children. Cushing syndrome. So a few definitions. Cushing syndrome is chronic excess glucocorticoid activity of any etiology. Cushing's disease is pituitary ACTH secreting state, which then causes excess endogenous glucocorticoid release. So Cushing's disease is a cause of Cushing syndrome, but there are many other causes of Cushing syndrome, which include adrenal tumors, again causing primary endogenous glucocorticoid production. You can have ectopic glucocorticoid production through malignancy, often lung, and then iatrogenic, probably the most common, meaning we give our patients steroids as the most common cause of Cushing syndrome. The manifestations, I'm sure most of us have seen this in one situation or another. So they have central obesity, which involves the face, neck, and abdomen, moon faces, the buffalo hump. They can have exophthalmos. Growth retardation is very common in children who have Cushing syndrome. Osteoporosis, poor bone health is very common. Muscle wasting, skin atrophy, easy bruising, they're very much at risk for developing significant striae. You can see hyperpigmentation with Cushing's disease, again, this hyper-ACTH state. Symptoms of androgen excess, including acne and hirsutism, a lot of emotional issues, which is often we see with patients who are on prednisone, glucose intolerance going on to diabetes, and of course hypertension. So just a quick case example, transitioning our topics here. So you have a 15-year-old boy in your clinic here for a well visit, very benign past history and review systems, and the MA gets an initial blood pressure of 130/82, and the BMI is slightly elevated. So two possible scenarios. One, you repeat a blood pressure, a manual on yourself, of course you do, and it is normal, 114/70. Or you repeat a manual reading yourself and it is elevated. You actually confirm what the MA has found. So for the first, this is something we might call white coat effect. And essentially this is nothing. This is irrelevant. And we would strongly advise that you actually eliminate the first reading from the patient's chart. Because oftentimes, if there's a question of hypertension, we do look for trends. And when we see these disparate readings, it is often hard to really identify what their blood pressure trend really is. So it could be due to the manual reading, how it was taken, the patient was rushing in. Whatever the case may be, if you've confirmed a normal manual reading, we would recommend eliminating the first, and it is really of no clinical significance. On the second, you've really kind of started the question of whether or not this child has true hypertension. And the first question in this child who is overweight could be the differential of white coat hypertension versus essential hypertension. So before we get into white coat, I do want to comment on one other diagnosis called masked hypertension. So this is actually the inverse of white coat hypertension, where in your clinic, their evaluation, their blood pressure is actually normal. But when you do home readings or especially nighttime readings, the readings tend to be elevated. This is estimated to be seen in up to 5% of adolescents, usually in children who are obese and have a strong family history for hypertension. This is important because this type of hypertension does carry a significant cardiovascular risk. Now you might ask, why would you even look for this, right? If they're normal in clinic, why else would you look for other things? And this is usually concurrent with a child who has a variety of cardiovascular risk factors, right? Strong family history for heart disease, diabetes, hyperlipidemia, again, morbid obesity. These are patients where you might consider some additional more invasive hypertension evaluation as these patients may be at risk for masked hypertension. So white coat hypertension, again, this is a scenario where the readings are elevated in clinic, but very normal at home. And this is very real. We've seen patients who have very dramatic differences in their readings in clinic versus what they do at home. The optimal confirmation of this diagnosis is through ambulatory blood pressure monitoring. And so what we do is we provide a blood pressure cuff with a fanny pack monitor, and the blood pressure cuff takes readings throughout the entire 24-hour period, every 20 minutes while awake and every 30 minutes at night. And they're able to provide us with this large amount of data for their blood pressure trends throughout their day. In addition to looking at the overall blood pressure readings, we are looking for something called nocturnal or nighttime dipping. With normal physiology, your blood pressure should drop about 10 to 20% at nighttime. And with patients with hypertension, very often we will not see that nighttime dip, which is very much an issue and a risk for cardiovascular disease. If you don't have the opportunity to do the ABPMs, certainly intermittent home blood pressure monitoring may be sufficient. You don't have the benefit of the nighttime monitoring, but it certainly is a way to get readings in different settings. What's important to recognize with white coat hypertension is that these patients are not overtly anxious, right? They don't have this kind of tachycardia, jitteriness, and they don't show really overt stress. Very oftentimes these are patients that we've known for years and very good relationships with them, and yet they come, and every time they're in clinic, their blood pressure is elevated. The big question is, what is the significance of white coat hypertension? Is this something that needs further evaluation, further follow-up, or do we just dismiss it completely? And the short answer is we don't know. The literature is very mixed. Some perceive this as a precursor, kind of a harbinger for true hypertension, and others state that, again, has no clinical significance at all. Again, the general recommendation for children is to continue to monitor the blood pressure yearly regardless, and so that's usually what we recommend for these patients. Essential hypertension, again, we very much know this is increasing in incidence in adolescents. Some of this might be because of the prevalence at which we screen children for hypertension, but certainly there's an increased association with the increase in obesity in our population. And the majority of these patients do have a positive family history for both obesity and hypertension. Once you identify essential hypertension in a patient, it's important to evaluate all other cardiac risk factors, including smoking, glucose intolerance, and diabetes, and hyperlipidemia. Other things to consider in an adolescent with hypertension, certainly with a variety of medications, OCPs, beta agonists, tricyclics, stimulants, ADHD medicines are certainly something to consider. Illicit substances certainly should be on your kind of review systems. Caffeine, so certainly any opportunity I have to recommend that children decrease their caffeine intake. Hypocrisy, true here, but for children, of course they're children. So any opportunity we say to decrease caffeine intake, we take it. In actuality, to actually say that there are studies that say that caffeine is a primary cause for hypertension, really those data do not exist. So I don't lie to families, but I say, it wouldn't be a bad idea to decrease caffeine intake overall for your child. All right, moving on to hypertension emergencies. As I mentioned, there are two different types of hypertension emergencies. The first is malignant hypertension. Malignant hypertension is severe, very significant hypertension with evidence of end organ injury. So in adults or in older adolescents, we're talking about readings with diastolic blood pressures greater than 120, so very, very elevated. So again, we're looking for evidence of end organ injury, which could include retinal hemorrhage or exudates. They could have papilledema. They might have moderate high-grade proteinuria. They often have very severe left ventricular hypertrophy and sometimes diminished ventricular function. This can be seen with essential hypertension. In fact, in adults, the most common cause is undiagnosed, untreated essential hypertension. But in children, undiagnosed renal artery stenosis would be classic for this kind of presentation. Usually, these patients have zero symptoms. Occasionally, maybe a little blurry vision, something like that, but the majority of these patients have no symptoms whatsoever when they present to you. The second emergency is hypertensive encephalopathy, and this is what most of us think of when we classically talk about emergent hypertension. So this is an acute rise in blood pressure, which results in cerebrovascular leak and cerebral edema and the subsequent neurologic symptoms that are part of this. So the absolute blood pressure reading is actually usually lower than with malignant hypertension. Because of the chronicity and gradual rise in malignant hypertension, the body is actually able to compensate and accommodate that increased blood pressure, which is why usually they don't have symptoms. In hypertensive encephalopathy, it is the rate of change that is the issue. It is a sudden rise which causes the acute neurologic symptoms. Certainly something I hope you don't see very often, but preeclampsia certainly has been described with hypertensive encephalopathy, but also a variety of acute glomerulonephritis. So post-strep GN, one of the worst complications that can occur with this, what we consider maybe a relatively benign and self-limited disease, these patients can develop very acute and severe hypertension, and so monitoring is very critical for these patients. And again, their symptoms are largely neurologic: headache, mental status changes, and seizure. Let's try this in. There we go. All right, so in the first slide, you see evidence of the retinal hemorrhage, which can be seen in malignant hypertension. And in this slide, we're looking at the MRI for a patient with hypertensive encephalopathy. And these changes in the occipital portion indicate that cerebral leak, which is what leads to the seizure and neurologic symptoms. All right, last category in the last 3 minutes, talking about drugs. And again, the goal here is not that you should really be prescribing drugs, but to really understand their basic mechanism of action and the potential side effects for the different medications. So the first class is thiazides. We're talking about chlorothiazide or hydrochlorothiazide. In the adult literature, this is generally considered to be first line for essential hypertension. The reason being that the majority of adults, up to 2/3, will have some degree of salt sensitivity as cause for the hypertension. There have been some very dramatic studies showing that for these patients, you can give them a saline bolus and watch their blood pressure dramatically rise as a result of the sodium administration. This incidence is actually increased in African American patients and in obese patients. And for that reason, if it is related to salt, diuretics are a very good drug to counteract this mechanism of disease. Generally, these are very well tolerated. Thiazides are a very gentle diuretic. Usually the patients often don't really notice a significant change in the urine output. But certainly because, again, this is a diuretic, sometimes you can see some electrolyte changes, hypokalemia being one possibility. Next category is ACE inhibitors. So we're talking about your prils, right? Captopril, enalapril, lisinopril, et cetera, et cetera. This is optimal usage for unilateral renal artery stenosis. Again, those patients have a very high renin-angiotensin state, so an ACE inhibitor is an ideal drug for hypertension in those patients. It is also can be used for proteinuria, and is something we often use with infants with hypertension. It does cause afterload reduction, and the mechanism within the kidney is that you actually will cause afferent arterial vasoconstriction. So what this means is that blood flow into the glomerulus is slightly decreased. The effect of angiotensin is to optimize or increase glomerular perfusion to maintain the kidney's GFR, and ACE inhibitors will counter that, and therefore ACE inhibitors will actually decrease your glomerular perfusion ever so slightly. It is that decreased glomerular pressure, which is actually what is the reason why it works for proteinuria. You're actually having less pressure and less protein is being pushed out through the glomerular filter. However, because ACE inhibitors do decrease renal blood flow ever so slightly, there is risk for acute kidney injury associated with that and hyperkalemia. As many of you may know, ACE inhibitors also can cause cough. This is actually through a tangential pathway unrelated to the direct renal effects. It is important that these drugs are held if the patient is dehydrated. Again, because the drug decreases blood flow, if you have a patient who has acute dehydration from a severe gastroenteritis, for example, it is imperative that they stop their ACE inhibitor. We've seen scenarios where patients think they're diligent and they stay on their meds, even though they're puking, they try to get them down, and results in very severe acute kidney injury. Between the two mechanisms of dehydration and the ACE inhibitor effect, it can cause severe kidney injury in those states. The last thing, for any adolescent female to which you're prescribing ACE inhibitors, it is imperative that you document discussion regarding the teratogenic effects of ACE inhibitors. It has to be very clearly documented. And again, this could be even for the 10, 11-year-old that you're prescribing it. It is imperative that they are aware of these very important teratogenic effects of ACE inhibitors. Next, calcium channel blockers. So there are two classes, kind of the new and the old, the dihydroxypyridines, which are the amlodipine, nifedipine, which are what we use most often now. And then the older class, which is the verapamil and diltiazem. These are direct vasodilators. This is often our first line because when we don't know exactly what's going on, but we want to lower blood pressure, we often go to calcium channel blockers because they're incredibly well tolerated. They really don't require any lab monitoring at all. There are some adverse effects though. You can have some reflex tachycardia by having the direct vasodilation. The heart actually may respond by increasing the heart rate. You can see peripheral edema or constipation and decreased cardiac contractility. These side effects, generally speaking, are much greater in the older drugs, which is why we tend to stick with the amlodipine and nifedipine first line. Beta blockers, so propranolol, atenolol, metoprolol, labetalol. These can be beneficial in patients with headache and hypertension. The adverse effects, these are very important to remember. These can cause bronchospasm and can facilitate hypoglycemia. As a result, these cannot be used in patients who have asthma because they require beta agonists as a rescue medicine, which will be blocked by beta blockers. And also diabetics, because if a diabetic patient actually develops hypoglycemia, it's critical that they have the symptomatology, the jitteriness and that kind of thing, so you know their blood pressure or blood sugar is low. And beta blockers will actually suppress those symptoms and could actually facilitate fatal hypoglycemia. Back in the 90s, there was actually some discussion and question about whether or not beta blockers actually worsen depression and can actually cause suicide. This has been refuted. However, the primary side effect of beta blockers is fatigue, which is why this is usually never our first line choice for hypertension management in children. All right, just 2 minutes over, a couple quick questions. So first, which is the least likely etiology of hypertension in a patient with neurofibromatosis? Right, so it is D. So vascular changes, whether it's coarctation or renal stenosis, are associated, and of course pheochromocytoma, well-described association. And then the last question, I think, which is the best diagnostic test for white coat hypertension? Echo, random renin level with urine sodium, and ABPM, or intermittent home blood pressure monitoring? Which is the best test for diagnosing white coat hypertension? Yes. Right. So again, intermittent home blood pressure monitoring is kind of a secondary option if you do not have the option of ABPM. If you can do it, ABPM is by far the superior option because of the ability to monitor blood pressures throughout a day and also at nighttime. Oh, one more, sorry. 17-year-old obese male with a very severe elevated reading at a well visit, meaning he's well, which would not be part of his initial evaluation. Urinalysis, head MRI, retinal exam, or renal vascular ultrasound. Which would you not do? Great, exactly. So this is a patient, again, because he has severe hypertension but is asymptomatic, this is malignant hypertension. So we're looking for nephropathy, eye changes, and again, renal stenosis being a possible etiology for his situation. Thank you.